This is No Operating Manual, a podcast about building healthcare companies when there's no one clear path and no operations manual. My guest today is Nima Roohi, the CEO and co-founder of Blooming Health. For the past 5 years, Nima has been building Blooming Health alongside community organizations, health systems, and public agencies focused on helping people actually find and access social services. Blooming Health is working to create a single, reliable touchpoint for social care and a system that's often fragmented and difficult to navigate. Today, we'll talk about what it takes to build infrastructure for social care, what has changed since Blooming's early days, and what 5 years of this work teaches you that you never thought you'd learn. Nima, welcome to the show.
Hi, Erin. It's a pleasure to be here. Thank you so much for having me here and looking forward to the discussion.
I'm so glad that you're able to join us. So I'm going to jump into it because, like many founders, Blooming Health came from an experience you had with the healthcare system. Can you share a bit about your experience and how Blooming Health was born?
Yeah, for sure. The Blooming Health was kind of the outcome of a couple of different experiences and both professionally and personally, but also kind of societal trends that have happened in the past decade that me, my co-founders, and our team have been interested in exploring. A couple of them to mention is kind of professionally prior to kind of starting Blooming Health, I was running a data science and AI team working on medical record data sets around patients, kind of historical medical data, and building kind of machine learning and predictive tools on the top of that data set, predominantly being used in kind of hospital settings. And one of the things I learned in that kind of professional experience is that when we're trying to kind of manage risk for population, we don't really today in the population health segment, we don't really have a lot of deep understanding of the social risks. We have a lot of information about people's historical medical information, like their lab results, prescription intakes, hospitalization, etc. But we don't know whether they have enough food on their table. Do they have a right to go to their next healthcare appointment or not? Do they have a kind of stable housing to live in, or are they showing up to hospitals because they have no bed to sleep on in the night, and so on and so forth? That was kind of my professional side of the experience. Personally, I was also a caregiver to a loved one that was diagnosed with cancer, and we as a family had to navigate the process of providing care from kind of figuring out how to get the right provider for our loved one, how to get our loved one to that provider on a weekly basis to get treatments around cancer, how to think about non-medical angles like how to make home walking safe for someone that has got a very serious kind of treatment, how to get them medically tailored meals, and so on and so forth. All of those challenges made me kind of understand the importance of non-medical angles of healthcare that impacts healthcare outcomes and impacts access to care. Imagining that is a repeated kind of challenge for many families across the nation made me kind of think about this problem a little deeper. It just happened that I got to also connect with two amazing people, becoming my two co-founders as a part of a community in New York City where they had very similar experiences in their lives, providing care to their loved ones, having some professional experience within healthcare in product and sales, commercial, go-to-market. And it just kind of, we came together very in a very complementary way of our kind of skills and capabilities, and also this kind of unified mission to address some of these problems. And all of this happened when another kind of huge trend in healthcare was happening around the world, especially in the US, which is when COVID happened. And that put a huge stressor and load on many of the kind of infrastructures that enable access to care, that kind of provide healthcare to people. And a lot of the pieces of that infrastructure started breaking apart because of the kind of shift in the demand for those types of kind of services or care, including the fact that a lot of people no longer could easily show up to a hospital or show up to a clinical setting and receive care. And so all of that was kind of a long way of saying that personal experience, professional experience kind of almost made it inevitable for me to personally work on this problem as a part of my career.
It just kind of collided all at once.
100%.
So you spoke a little bit about your earlier career in data science, and actually you have a PhD in computational mechanics. So when you think about social services, and again, these social determinants, oftentimes you think they're not really predictable. or optimized, but that's really what you're working on at Blooming Health. So how do you and how did your team begin to think about social care and social determinants a little bit more predictably?
Yeah, so that's a really good question. That in fact is one of the core problems within social care. Meaning that if I were to kind of explain the three kind of core problems or gaps within social care that impacts healthcare outcomes, and keep in mind there's plenty of body of research showing that around 80% of healthcare outcomes are actually impacted by services and interventions that happen outside medical facilities that we use social care as an umbrella for, but like this means like the food you eat, the kind of access to transportation, benefits coverage, and so on and so forth. But the problem that we face as a nation is one of the core reasons that our healthcare cost is so high is that we don't have the same level of sophistication in addressing the needs within social care ecosystem as we do within medical care. The three core problems that I mentioned are these. The first one is that within social care, you have plenty of fragmentation. So every kind of category of your need you can imagine, like access to food and nutrition, housing, transportation and mobility, primary care, mental health coverage for certain benefits and healthcare and so on and so forth, all of which kind of then results in you being a healthier individual. These are addressed by many different entities in a city, a town you live in, right? It's not like you go to a hospital and you get multiple different types of care there. It's like for food, you need one organization. For transportation, you need another one. So fragmentation is the first problem. The second problem is that we don't have enough data about people's needs today. You almost never get asked about some of these needs when you show up in your clinical appointments. You get asked whether you feel dizzy, whether you've done your blood work, whether you feel any pain or fever, etc. But just like the audience for this discussion, I would love them to ask themselves like how many times they have seen a nurse or a physician asking them like, "Do you have enough food to eat? How did you get to this appointment? Do you have a right to show up for your next checkup, basically, or not?" Right? That data doesn't exist. In fact, it doesn't exist, and it's a risk to the extent that a lot of health systems and plans end up paying for adjacent data sets to these types of needs, credit card payment data sets, and so on and so forth, to be able to risk profile their populations around these needs. And then the second kind of way they try to address this problem, which is the third problem within the broader social care ecosystem, is scalability of operation. Basically, systems and plans try to hire more care managers, community health workers, social workers to help manually screen people for different needs so that that data then could be used in kind of risk profiling those populations and dollars invested in these services that can close the gaps and address the needs and so on and so forth. The problem is that solution, meaning hiring more people to screen people and kind of collect that data, is not scalable. It's not equitable. Meaning that in a city like New York, you have a very large system having millions of patients. And for that, you need thousands, if not tens of thousands of care managers. And you need them to be able to speak like 80 different languages because it's a very diverse city. And you need them to be able to engage with these people really kind of frequently and longitudinally because social risks are very dynamic risks. You might lose a spouse and then all of a sudden you face a lot of risks that you didn't face a month ago or a week ago. Or you might lose job and lose income and as a result face a bunch of risks that you didn't face a month ago. And a lot of that information, because it's dynamic and not static, you need to collect them frequently. All of that means that collecting data is very hard around social risk profiles, which makes it then harder to use any meaningful data to invest dollars with clear returns on investments by health plans and health systems, right? It's very hard if you don't know who are the people that are food insecure. It's very hard to help those people address those needs. Right? That's really kind of part of what made us really interested in kind of digitizing and bringing the power of technology in this ecosystem, which is a pretty kind of, I'd say, old school ecosystem from technology perspective, to be able to bring more scalability and equity in data collection. Then when you have data, what we have been trying to do is basically then use that data for better dollars allocation, better service kind of delivery to people that actually need it, where you know that, hey, if I contract with Uber and I provide rides to my patients, I actually can figure out which of the patients that need these rides in a timely manner to show up for their appointments. Like a mom that just given birth to a born and needs to show up for baby's vaccination or wellness checkups. And the problem that mom faces is they don't have a transportation mode to be able to take that baby to the appointments. If I can figure that out, I can reduce the probabilities of complexities post-delivery, potential rehospitalizations, and so on and so forth, which is a huge cost element for hospitals and plans. That's really how kind of, I would say, a multi-layer analytics solutions can come in and play a role in this ecosystem. But the first problem is really the foundational problem. You only can build analytics and predictive tools on the top of quality data. And our first job was, let's just figure out how we actually collect that data and help organizations collect that data and then use that data for better resource allocation.
So Blooming Health is collecting that data. They're giving that information to health systems. They're able to do, like you're talking about, getting those Uber rides for folks who need to get to appointments, whatever. But how does that work on the social service side, on those organizations that are providing additional services, connecting folks? So, you talked a little bit about care managers or caseworkers or whatever it may be that, are connecting to those social services. But if you take that element out, how do you connect those folks back to those social service organizations that are in their community that they can, basically use for resourcing?
Yeah. So actually, this is a very good question. It's just kind of going back to the spirit of this conversation in this podcast, where you don't have an operating manual, and then now you're trying to solve a problem within this very complex ecosystem where you have health plans and health systems. You have got community-based organizations or service providers in the social services space. You have actually a third player, which is government, because government also funds those social service providers. And then you've got the fourth stakeholder, which are the patients. One of the more complex ecosystems within the healthcare ecosystem. As a startup, when you come into it, you're like, all right, this is a nightmare because I don't know which one of these stakeholders I need to build a product for, and which of the kind of relationships I need to satisfy first. Obviously, with limited resources, I cannot do all of them. We actually did quite a bit of research early on, market research, to understand the dynamic between these four stakeholders, between kind of government, healthcare, community-based organizations, and patients. And we also did quite a bit of research to understand how other technology companies have approached the problem in this ecosystem, the gaps that exist. And we learned that most often than not, the operating manual tells you go where the money is and start from there all the way to where the need is, right? Because as a business, you need to be able to sell, and you need to be able to generate revenue, and you need to be able to show traction so that you can survive, right? We made actually a very counterintuitive bet here. The counterintuitive bet we made was this: that social service organizations, while they don't have the money for you to build a venture scale company on the top of, they're the critical stakeholder to deliver quality last mile interventions in the communities to the people that live in those communities that will actually end up reducing cost of healthcare for everybody else within the ecosystem and improving the quality of life for the people in that ecosystem. And almost every technology company that have tried to solve problems within this ecosystem has started from payers and plans, went to government, then came to social service providers, then to the patients. We reversed this playbook on its head. We're like, let's pick up these two elements, people and community-based organizations, and let's build a product that empowers community-based organizations, scales their operation up with the power of AI and automation, helps them to do more with the existing resources they have because they don't have a lot of money, and then help them deliver more data-driven, high-quality services to the population they're serving. Because every time you talk to a plan and system, the first question they ask, who are the community-based organizations you're working with, and how can you tell us that they're going to actually save money for us, not just kind of be another source of us spending dollars on specific services, right? That's why we first built a solution in 21, 22. We spent like the whole time, we didn't even go and try to, we talked to plans and systems, but we didn't try to sell into them because we wanted to see what they're looking for from these interventions. And we built a solution that basically improve the capacity of these community-based organizations by 3 to 5 times, meaning that they could do a lot more with the existing financial resources they had. They could show a lot more capability in collecting data from population, providing services in a timely manner, measuring the outcomes of those services, and measuring the satisfaction of the people that are receiving those services, and kind of showing the capability that they could be a data-driven solution to work with health plans and health systems. Then, as we built critical mass of these community-based organizations in a geo area, let's say in New York City, in Cleveland, in Dallas, in Houston, in Los Angeles, we went up into the value chain and we went to the systems and plans and we're like, hey, we're working with your population. We're helping the organizations that are serving your population, some of which you already have contracts with. But we have a technology solution that can make your job easier on figuring out where to funnel dollars in and who to help within the population. We can help you have a lot less fragmentation in your contracting with these organizations. And we can help these organizations to provide higher quality, better outcomes and services to your population. We already have proof of it for 2 years. Like, you don't need to run a pilot on this. We already have it. And then why don't you pull the trigger and open this up for more of your population and more of the kind of service providers. And then this way, we call it bottom up, then top down go-to-market strategy. We first built a critical mass bottom up. We created product market fit bottom up. Then we went top down, and it was a lot easier to convince top down organizations that, hey, this is going to actually work.
So when you're talking to those community-based organizations, I'm thinking about the CBOs that may not have contracts with those health plans, right? They truly are a community-based organization and they're doing things off volunteer and dollars. So how do you talk to them about the data-driven approach that you bring to the table in order to, what does that look like for them in those organizations versus, I mean, I understand someone has a contract with a health plan and they're delivering on that, but how do you scale something that may be altruistic?
Yeah, for sure. So the way we look at it is this. We look at the CBOs in like 3 categories, basically. There's the first category of CBOs that actually have contracts with healthcare. They are kind of somewhat disciplined to that level of operational capacity needed. They have the infrastructure. Sometimes they have the understanding what the plans and systems expect, and so on and so forth. Second category are organizations that don't have those contracts, but they want to have those contracts and they want to build up that capacity to get those contracts. The third bucket are the ones that don't have those contracts and they're not interested in having those contracts, meaning like they either don't have the capability, they're not really kind of built up that way. They're like very focused on specific areas of social services that they're just having either contract with grants or government and so on and so forth, and they just want to continue to do that, right? Our interest is in the first 2 buckets predominantly. Right? The first bucket is very clear. They have existing contracts with healthcare. They see the value of a kind of a technology solution like ours very, very much kind of immediately because it helps them multiply those contract values and multiply the population they can serve immediately through technology capacity building. Right? Just to kind of as a reminder for people that are listening, our system is kind of it's an AI agentic system with agents that have vertical expertise in food insecurity, housing, transportation, primary care access, benefit continuity, care transition, and so on and so forth. That sits on the top of a service provider network or marketplace that can basically provide to the health plans or health systems an equivalent of a care management team with a network of service providers to address their population needs. And it provides to the community-based organizations or service providers a operational capacity building or a care management team that can help them then service those people and also other people that they're serving, not just people that are getting referrals from health plans and health systems for. So going back to our 3 categories, the first bucket, they're typically ready to go. The second bucket, there's a transition process, basically, meaning that when we partner with them, the first step is really kind of building up that capacity for them to be able to kind of scale up or at least have some preparation for scale up of the operation. The primary reason you need a scalability there is that most plans and systems don't want to loop in hundreds of service providers. It's just that fragmentation is a headache for them, right? So as a result, they want to work with food banks that are able to spin up new geo operations really quickly if there is demand. If there's money flow, they're able to do that, right? And that's a part of basically how we vet some of these community-based organizations. In fact, the way we work with community-based organizations is that we don't really generate revenue from them today. We provide our product for free to them. We give our product for free to them to build that capacity, so that when we bring them to the table to the plans and systems, if they're asked, like, can you serve 1,000 people? Can you serve 10,000 people? The answer is yes. Now, the transition process here, as you mentioned, is basically from a kind of a mom and pop shop, if you will, an operation that is predominantly set up on grants and volunteers, into a more kind of professional operation that can actually hire people and can expand operation, that can actually provide services at bigger scale. We typically work with these two buckets predominantly because the third bucket is not really interested to work with systems and plans. And typically there is a kind of a lift-off period. That's why we typically build our bottom-up motion way before we build the top-down motion, meaning that we enter a geo area and build that network way before we enter that market for health plans and systems.
That makes so much sense. How much time do you spend building that market before you go into market to top down?
Yeah, so basically it's a calculated process. So for our product to be adopted by an organization, it typically takes them basically just 2 weeks. Technically it could be up and running in a day, but typically on average takes 2 weeks because we're not the only thing they're kind of prioritizing and working on, right? 2 weeks is really the timeline we need to get an organization up and running. That means that if you build in the process of engaging these organizations and then converting into an active node that are using the product, you typically need a quarter time because you need to go engage them, educate them, get them to deploy the product, build up that kind of use case portfolio that they could, because typically these community-based organizations, they're not just focused on food insecurity. There's a variety of services they provide: food insecurity and nutrition, housing. Some kind of have some transportation networks that are attached to them. Most of them have kind of care management systems, social services solutions to be able to provide enrollment in Medicaid, in SNAP, and so on and so forth. So there's typically a portfolio of them that adopt our product basically in a sequencing manner. So that's really kind of, I would say, the calculated process. Like if we were to go and take over the city of Dallas, that's typically a quarter of time.
Okay, that's good to know. So switching gears a little bit, founding a company kind of leads to a lot of ambiguity, right?
Yep.
So what has surprised you most about leading Bloom Health?
Yeah. It's interesting because building a company out of nothing is it's a continuous kind of learning process. It's almost like the fun part of it is both the fun part and the stressful part is that every day you're learning new things, right? So if you're not comfortable with change, this is not probably for you because things change almost every day, right? I think there's a couple of things that I've learned along the way that have been really interesting for me. The first one is that it is important that you have a mission as a company, meaning that if you have a worthy mission, people will go the extra mile for that mission. They won't go meaning your team, your customers, investors, the ecosystem advisors, they will go the extra mile for the worthy mission, which means that you could achieve a lot more with the same amount of resources. So I think our mission has helped us quite a bit along the way. When I talk to investors, most often than not, they're surprised how lean we are financially and how little we have spent financially to get to the point we're at right now. And I know in the back of napkin calculation that the reason for that is really a lot of people are doing things for the company's mission without even thinking about that short-term financial outcome. That's the first thing. The second thing is the importance of talent. One of the things I've learned that if I wanted to give advice to my 5 years younger person is the most important thing as a founder CEO you can do is really bring in the highest quality talent that you can afford. Like that's where you should not be stingy. You should not be kind of be worried about kind of overspending. This doesn't mean overhire, but for whatever you hire, don't settle for low quality. A few low quality talents could basically wreck a company, and if the company is very very kind of um, like very much on a success path, and vice versa. A handful of high quality talents can actually i- increase the odds of a company being successful. And then the third thing I would say is I mean, these are not necessarily surprises. I know you asked for a surprising kind of thing, but like these are not surprises, but these are stuff that you'll hear from everybody. You almost ignore them, and then you learn it on your own, and you're like, all right, I wish I've listened to it early on. And then I would say the last thing as a startup is like that's important for a company success like ours is that you need to have real focus. Most often than not, what I've seen, I mean, this includes myself, founders and CEOs, because they want to be visionaries and like they have this fancy, I would say, view of what a founder should be. Like, let's build the iPhone, let's build the next kind of social network and so on and so forth. They almost kind of lure themselves into, we need to build a company that does everything or does very huge things. And most often than not, that results in kind of spreading yourself really, really thin. And again, this is one of those advices or one of the things that when I'm telling people this right now, they're going to ignore it, and that's okay, but they're going to learn it in a very, very fast kind of few cycles, that it is okay for you to solve a very, very simple, boring problem, but solve it really, really well. A problem that has people hair on fire, and you're going to be a successful company. You don't need to boil the ocean early on.
I love that answer. Not every problem is, visibility, especially if something that you're working on right now, that it should really. So just plugging away. You
100%.
mentioned 5 years ago, and you founded your company right before the world shut down in a global pandemic. What did you learn through that process, and what was the benefit of the shutdown to development?
Yeah, this is a tricky topic because I'm based out in New York, and New York was the epicenter of the pandemic early on, of globally and in the U.S. New York faced one of the worst case kind of scenarios out of the pandemic, especially in the early months of the pandemic. So a couple of things happened, two or three of them that are kind of important to mention. And I want to mention that some of these are silver linings of the event, meaning like we lost a lot of people during that event, and it's just heavy and hard to kind of retro on that. But one of the things that actually made us move a lot faster early on was the lockdown in New York City. So here's what happened. Basically, pandemic hit New York City, and I think the city went on a lockdown in March or 2020 or something along those timelines. And when the city went on lockdown, we had millions of people in their homes, especially at a time like older adults that were deemed high risk individuals as it related to the COVID-19 virus. Especially people with multi chronic conditions were at high risk of mortality if they actually got the virus early on, COVID virus early on. So they couldn't even go grocery shopping. They couldn't go pick up their prescriptions. They couldn't go to their kind of healthcare checkups. All of those exposed them to risks. The problem was a pandemic at this scale, similar to kind of some of the topics we talked about today. There's no operating manual for a city and like how to handle it. It's not a very kind of well-defined operating manual. Let's put it this way. So a lot of entities, stakeholders in New York City were trying to reach these people that were locked into their homes, and were trying to figure out how they could help them get access to food or groceries, get access to their prescriptions, get access to some doctors, so their chronic conditions did not result in the need for hospitalization or ER utilization and so on and so forth, which again, reminder for everybody, hospital beds were all full at the time. So it was almost impossible to admit someone with kind of chronic conditions into a hospital without kind of exposing them to a kind of a mortal outcome, basically. That problem was something that needed a very resilient and robust solution, because you needed as a solution there that could be very adaptable to all sorts of population cohorts, people that didn't have access to technology, people that didn't speak English, people that had hearing, vision impairments, and maybe like older adults that didn't have their children around, that got their help in navigating healthcare before, but they had no access to them right now. All of that meant that there's need for some solutions that bridges that gap of engagement, especially between community-based organizations and people, because community-based organizations were tapped by government and healthcare to reach those people because they were the only organizations people trusted, basically. And if you remember, there was a lot of misinformation around the pandemic at the time. So we kind of leveraged this opportunity because it kind of mapped really well to the problem we're trying to solve. And we fast tracked basically building a solution that was very scrappy early on, but an AI-based engagement solution that could help these community-based organizations call people, text people, email people, and talk to them in any language they spoke, and just run these check-ins, wellness check-ins, and collect that data that we talked about early on about their needs, and then bring it back for operations to dispatch different types of solutions to it, from meals being delivered to people, helping kind of picking up prescriptions for people, connecting them to basically teledocs or kind of virtual health kind of setups and solutions. We ran that, and we actually didn't even have a product interface. We had a piece of code, and we talked to a bunch of community-based organizations in New York, and we're like, if you have a list of people, like you have 1,000 people that you need to call, and you only have 5 staff, and you're only able to make, I don't know, like 20 calls a day, we can do that in an hour for you. Just give us the list and what you need to run. We feed it into our system, we'll run it for you. And then we did it. And then as we started running it in New York City, New York State government took notice of that, hey, these guys are kind of deploying the solution in Bronx, New York, in Brooklyn, Queens, New York, in East Harlem, New York. And then state of New York was like, hey guys, like we need to use this also in rural areas. Rural areas face the same problem with the additional complexity that older adults might not be able to drive somewhere before kind of anybody knows they have a need. And we need to be able to call them. And the other problem is that most of these people only have landline. We cannot ping them on their MyChart app or like another kind of type of solution. Helped us bring a solution to the market that I would say in a normal setting might have been much more hesitant to deploy a solution as scrappy as ours. Just out of pain they need a solution. And we leveraged that process to get more feedback, more adoption, and then put our blood and sweat into it to improve it. And then by late kind of 2020, early 2021, we have a really kind of polished product that we deploy through New York State, and we deploy through City of Yonkers and so on and so forth. And from there, kind of the rest of the history is like to today that we have this product that is in hands of like 6 million people across like 27 states. So it wasn't out of just kind of chance that this happened. At that point, we've spent 2 years talking in the communities with community-based organizations, with people understanding that need really well. Like we didn't came very naively being like, let's understand what community-based organizations are doing in a pandemic setting. We already knew what their challenges were. We came in with a solution and gave it to them when, unfortunately, their hair was on fire with a very kind of massive problem that was globally big, but in New York City was like orders of magnitude more challenging to solve.
You had already built up that trust with those CBOs before the pandemic. And so that trust just kind of carried through as they were trying to solve this problem for their populations. And you were there to be able to help them do that. So I think that right time, right place, definitely, but also doesn't go into the, all the other pieces that the work that you had already put in at that point in time. Before we wrap this up, what's next for Blooming Health? What do you see on your horizon now?
Yeah. So we are kind of a growth startup at this point. So we're like in kind of startup terms or Silicon Valley terms, we're post kind of Series A or Series B right now. And we have kind of scaled up our operation, serving around 6 million people. We work with hundreds, actually, I think around 1,500 programs and organizations across 27 states. We work with government, healthcare, and community-based organizations. Right now, what's coming next for us, what we're focused on is that we have built a lot of capacity bottom up in different states where we're trying to leverage top down, especially understanding in the current environment where, keep in mind, a lot of people we serve are Medicaid and Medicare population. As you know, Medicare and Medicaid are all government covered kind of insurance. We know that the word of the day today around Medicaid and Medicare is better efficiency, lower cost, and more kind of scalability. What we're trying to do is basically leveraging the networks that we have established in the states we're active in and our technology, which is a very cutting edge solution to be able to bring a trusted, robust kind of care management automation operation into the kind of social care. We even actually don't call it social care necessarily. We're just removing barriers for access to healthcare and better healthcare outcomes. That's really kind of the gist of what we're doing. And what we're doing right now is really kind of focusing on partnering with more health plans and health systems, top down, basically, to be able to bring more of this coverage to the people in the communities that we already are active in. I think we have kind of created a model at certain level of scale that is working. I think, again, historically, the difference between us and most of the other technology companies in our ecosystem is that we didn't solve it first for plans and systems. We first solved it for patients and community-based organizations. And because we have the stickiness there, because we have basically the adoption there, we're leveraging that to now partner with health plans and health systems across the nation and bringing better access to care for the people we're currently serving or the people that are within the networks we're serving, but we're not actively serving right now in partnership with those plans and systems. And also kind of part of our mission is to bring this awareness around how important it is to think about healthcare a little bit more holistically if we are serious about reducing cost of care. You cannot be serious about cost of care if you're just adopting AI within your hospital systems. Like that's not where most of the cost gets kind of initiated. That's where most of the cost gets consumed, but most of the cost gets initiated back in the communities. And that's really kind of where we're trying to bring more awareness that actually health plans, health systems, and states can invest in more robust infrastructures in the communities, can then in turn reduce a lot of cost of care downstream for all of those states.
Thank you. Thank you for summing that up so easily and succinctly. And thank you for sharing Blooming Health's story and your story and for being on the podcast.
I appreciate it. Thank you so much for the opportunity, and hope this was a productive discussion for the audience.
Thanks for listening to No Operating Manual. If you enjoyed this episode and you'd like to support the podcast, please leave a rating and a review, and don't forget to subscribe on YouTube. No Operating Manual is hosted and produced by Aaron O'Brien of Chemistry, a healthcare marketing and communication advisory. Visit our website at choosechemistry.com.